This is a PowerPoint presentation for Nursing 524 on EMDR therapy modality. In looking at the overview of EMDR therapy, EMDR, as we know, is eye movement desensitization and reprocessing. It's an evidence-based psychotherapy. It's been used since 1987 and was developed by Dr. Francine Shapiro. Its primary focus is that of reprocessing traumatic memories and is used mostly for PTSD, but there are many other carryovers through depression, anxiety. There's even been some research done for use in migraine headaches. The neurobiological mechanisms of EMDR involve the AIP model, which is adaptive information processing, as well as bilateral stimulation. Through these two processes, we know that traumatic experiences can resurface time and time again. They're improperly stored and trigger PTSD and traumatic events. There are 8 clinical phases of EMDR, including a thorough history taking and treatment planning, establishing a therapeutic approach, and that's based on the patient's history, traumatic triggers, negative beliefs. Also part of the phases are reinforcing positive beliefs associated with the trauma, and I think sometimes patients don't think about the positivity of their trauma. Bilateral stimulation and neurophysiological effects of EMDR. There are mechanisms of actions as well as research findings, and bilateral stimulation is believed to facilitate the integration by engaging both hemispheres of the brain. So there's right and left brain interaction, and we are mostly using the right side of our brain during talk therapy, and EMDR brings that left side into play, which can rechannel, help us focus and categorize that trauma better. As we said in one of the previous slides, EMDR was primarily developed in 1987 for an additional psychotherapy for PTSD. In the years, research has shown that it's also very successful for anxiety disorders, including panic disorder, depression, phobias, chronic pain, grief and loss, dissociative disorders, and childhood trauma. And we will talk a little bit more in a later slide about dissociative disorders. I think this needs very careful planning and a careful, thoughtful approach because these disorders can easily be triggered negatively. Since EMDR was developed in 1987, there have been both randomized control trials as well as meta-analysis findings. It's been very supportive. There's a vast amount of research over the years continuing to prove EMDR's worth in psychotherapy and mental health treatment. Clinical benefits and considerations of EMDR involve benefits for both clinicians and patient. Some of the benefits can include a more rapid resolution of trauma-related symptoms, especially when paired with CBT therapy. It's non-invasive, and I know we've talked extensively in class about medications, therapy, particularly in light of going over the recent book Unhinged. I found it to be a support in light of not using medications as much as we do. Also, EMDR requires specialized training for optimal efficacy. It should not just be added to our repertoire without careful consideration and training and practice. It's not suitable for all patients, particularly those with severe dissociative symptoms or active psychosis. I think it needs to be double checked in these instances. And that's why I think requiring a thorough assessment is so important. I think it's very interesting reading through the research on neuroplasticity and EMDR, the impacts on the brain structure. We've touched on the right and left brain considerations in previous slides, and studies suggest that EMDR may promote neuroplastic changes by increasing the connectivity between the prefrontal cortex and the limbic structures. And as we know about the brain's activity, these can aid in regulating our emotions, which include depression, grief, trauma. As with any psychotherapy and treatment plan for patients, careful considerations of the limitations and challenges need to be thought through. Not all patients respond equally, and I know in my clinicals this semester we have followed 4 different patients that have been referred for EMDR. 3 of the 4 reported vast improvement in PTSD, depression, and panic attacks. The 4th actually had been going to more sessions than the other 3, but was reporting very little, if any, improvement. I also think that as we've talked about before, complex cases such as dissociative disorders, complex trauma may require a more detailed approach. In conclusion, I want to stress that EMDR therapy is a scientifically supported treatment for trauma, particularly PTSD, and offers rapid relief with sustained outcomes. It utilizes bilateral stimulation to facilitate adaptive memory processing and emotional healing. Also remember the other areas of depression, panic disorder, grief and loss. I think we've only touched the surface as to the benefit of this psychotherapy. And I think the next thing for clinicians to think about is considering incorporating EMDR into treatment plans. And I think we need more clinicians that are trained in this psychotherapy. I think we're going to see it's going to become a larger, more important component in psychotherapy.